talking about sudden cardiac arrest and public access defibrillations at commercial airports. So we're going to be shifting gears a little bit from our discussion of in-flight cardiac arrest to now talking about on-the-ground cardiac arrest. Much to the dismay of my parents, I have no financial relationships and also no real relationships. No conflicts of interest either. So let's set the stage here. August 10th, 2019, we're at Minneapolis-St. Paul International Airport. And I figured since we're at an aerospace meeting, I'll use both the IATA designation and the ICAO designation, so we'll keep everybody happy. We have Greg. He's a 60-year-old male. He gets off a flight from California, and here's what happens to Greg. And I want to emphasize this video is produced by a company that sponsors commercial products. This presentation does not endorse the use of any of them. So here we have Greg, stumbles a little bit and collapses. The arrest is initially bystander witnessed. We have the gentleman with the backpack at Greg's side, and we have this gentleman with the garment bag directing TSA officers. And we have TSA officers at the patient's side under a minute. And so he's agonally breathing at this point. So at this point, the TSA begins bystander CPR, and presumably one of them has called on the radio for help. So TSA comes back with an AED, apply the pads on. Airport bike cop arrives, and non-biked airport cop arrives. And so we have defibrillation. Patient remains in shockable rhythm. We have airport fire arriving with a manual defibrillation, and they apply positive, instead of chest compressions, they're applying active compression-decompression CPR with a plunger-type device. And they've also put an advanced airway, laryngeal mask on the patient. And so at the fifth shock, the patient's still refractory, and resuscitation continues. Eligard is a device that raises the head up. The idea is that it improves cerebral perfusion. The jury's still out as to whether or not that works, so I'm not going to endorse it here. And now we have the transporting EMS unit arrives, and the paramedic who's in white is going to establish intraosseous access and push both adrenaline and amiodarone. And so at around minute 17, we have a mechanical CPR device placed on the patient. And at this point, it appears at about 20 minutes they get ROSC. And so the patient re-arrests at 22 minutes. Gets more adrenaline and amiodarone. And so at this point, they make the decision to transport the patient while in cardiac arrest. And so patient is transported. And during the transport, they get ROSC and continue off to the hospital for post-ROSC advanced care, which is one of the key components in the chain of survival. So I'm just going to stop the video there and talk about some of the highlights of what we saw. So first off, the patient had the cardiac arrest. And the first thing we see is we have a number of people witness that arrest. That's very important because a witnessed arrest means you get almost instantaneous access to the emergency response system. You get bystander CPR, in this case TSA. So we have this gentleman with the garment bag. He notified TSA almost immediately. And then they were able to arrive and begin CPR. There's a question as to whether they were delayed in their recognition of cardiac arrest, but that's a topic for another day. Airport police came on scene. They had the AED. Airport fire was super quick as well. The ambulance crew arrived, and they did everything they needed to do. They initiated transport after about 26 minutes, and here's Greg, 2 weeks after his cardiac arrest. And arguably, nothing contributed to his survival better than the fact that he was at an airport. So what are the factors in an airport that specifically contributed to Greg's survival? First off, we had instantaneous recognition of the cardiac arrest and activation of the emergency response system. We had prompt bystander CPR and defibrillation events. I'm just realizing that every number in this bullet point list says 1, so my apologies there. PowerPoint was not on my side, unlike Nationwide. We had prompt bystander CPR and defibrillation attempts. We had timely arrival of professional rescuers. And we had high-performance CPR and advanced cardiac life support by professional rescuers and high-quality post-arrest care. So let's talk about cardiac arrest survival in airports. So cardiac arrest survival or out-of-hospital cardiac arrest survival nationally is really low. It's in the teens or the single digits depending on how you look at the data. But there's really no controversy that cardiac arrest survival in the airport environment is dramatically greater than cardiac arrest survival in almost any other public venue. So here in Seattle-Tacoma, we have 44% survival and 56.5% survival in Copenhagen. This is survival, neurologically intact survival to discharge. Here are my learning objectives for the talk. We're going to talk about the general predictors of survival for out-of-hospital cardiac arrest. We're going to describe the airport as a unique environment for out-of-hospital cardiac arrest. And finally, number 1, we're going to summarize literature on the topic of cardiac arrest and public access defibrillation and introduce some future topics for research and preparedness. So first off, just a general discussion of predictors of cardiac arrest survival. And this is going to be a lot of review, but I just want to make sure that we're all sort of speaking the same language, so my apologies if this is a little bit redundant. Cardiac arrest is any situation where the heart has stopped beating and is unable to adequately perfuse vital organs. And there are various causes for cardiac arrest. This can be anything from cardiac pathology like ischemia, arrhythmia, to non-cardiac etiologies, so maybe asphyxiation first then triggers cardiac arrest, overdose, traumatic injury, metabolic disturbances, and hypothermia. And so we can sort of plot the chain of events with different cardiac etiologies. So in the case of cardiac ischemia, we have ischemia of the myocardium. That leads to necrosis of cardiomyocytes, and then widespread cell death, compromised pumping. And then when we have compromised pumping, the brain becomes hyperperfused and we get cardiac arrest. In respiratory cardiac arrest, we have respiratory depression. This can be caused by foreign body obstruction, overdoses, or anything that leads to respiratory depression. That starves both the heart and brain of oxygen, and then we get cardiac arrest that way. And then we have traumatic hemorrhage, which we have decreased blood volume, and then we have the same sort of outcome. We have the brain and the heart starved of oxygen, and we get cardiac arrest that way. And so survival in cardiac arrest depends in large part on limiting hypoxic brain injury caused by what we call no flow. So when there's no flow, it means the brain is not getting any oxygen, and we have neuronal cell death, we have ischemia, we have hypoxic injury, and that's really what contributes to the death of folks in cardiac arrest, or at least a lack of neurologically intact survival. And early CPR can provide perfusion to the brain and other vital organs, whereas defibrillation can correct dangerous heart rhythms that may have precipitated the cardiac arrest. And as we talked about earlier, witnessed arrests are associated with greater survival. So we can kind of plot out, again, a sequence of events of cardiac arrest survival. So, we have cardiac arrest onset, and the heart is unable to pump blood. And we really have 2 pathways that we can go. If there's no interventions at all of our metabolically demanding organs are starved of oxygen. That's mainly the brain, but also the heart and the kidneys, and that leads to irreversible injury. And ultimately, when we have so much irreversible injury to both the brain and the heart, we have a failure to resuscitate. Now let's see what happens if we intervened. If we intervene and CPR supplies blood to metabolically demanding organs, we have a reduced risk of irreversible injury and an increased likelihood of ROSC. And then so I want to talk about the difference between CPR and defibrillation. So CPR is for any cardiac arrest, and it's to perfuse vital organs, and it only requires knowledge. Whereas defibrillation is used only for ventricular fibrillation and ventricular tachycardia, and that's to correct dangerous heart rhythms. And that requires a defibrillator or an AED, unless somebody has superpowers and can just give 360 joules like that, but I haven't read the case report. Graphically, this is what the various rhythms look like. We have ventricular fibrillation, we have pulseless ventricular tachycardia versus asystole or flatline, and then PEA. The famous one is you look at all the medical TV shows and they're shocking asystole, and everybody who's slightly medically inclined will cringe there. Differences between defibrillators and AEDs. All AEDs are defibrillators, but not all defibrillators are AEDs. What you see in hospitals are manual defibrillators. You're setting the voltage, you're pushing shock, you're interpreting the rhythm yourself. AEDs, you sort of plug and play, set it and forget it, and it'll do its thing. Good bystander interventions. These are 4 factors that behind good bystander interventions that I like to think about. So they're time sensitive, easy to learn and perform. There's limited potential for error, and they're life-saving. So now we can talk about, after establishing sort of the foundation, we can talk about the airport as a cardiac arrest environment. This is a typical airport terminal. I took this photo last week in John F. Kennedy International Airport. And there are 3 main factors that make the typical airport terminal really good for cardiac arrest survival. Number 1, open areas with many people. That leads to a lot of witnessed arrests. Number 2, you can see this gentleman way in the back there, but he's an airport security guard. And so airport employees allow for prompt CPR because more often than not, at least the security folks and the police officers have CPR training. And even if they're not, they sort of know how to activate the emergency response system and get professional help soon. And then finally, public access AEDs located throughout the concourse. So that leads to early defibrillation. We talked about witnessed arrests, and witnessed arrests can be both by bystanders but also by surveillance cameras, and this leads to quicker resuscitation and activation of response systems. So we can see that arrests in airports are far more witnessed than arrests in the general public, and as a result, we have much higher rates of bystander CPR, and then also as a result of there being police officers and security officers. Public access AEDs really started in airports, and prompt defibrillation of shockable rhythm is certainly associated with survival, and airports have been a proving ground for the technology. So this is AED use in Copenhagen and France versus in the airport versus the general out-of-hospital cardiac arrest environment. So just orders of magnitude more in the airport as opposed to the general cardiac arrest environment. Here's a map of 3 airports of Chicago of where the AEDs are. Here's a map of Hartsfield, Jackson, Atlanta, and here's a map of Copenhagen, Kastrup. And sort of the takeaway there is that if you were to create a metric of AED per square foot, there's no public area that has a higher amount of AEDs per square foot. You also have a quick access to responders. You have police officers. You have, in some airports, have paramedics on site. So Denver, they're on the 3-wheeler, and then in Heathrow, they're on a bike. And so now I want to sort of conclude with a couple of future directions. I only have a couple minutes here, so I'm only scratching the surface here. I think the future directions itself could be its own talk. But the first one is video recognition of cardiac arrest. So maybe we have, there are a ton of security cameras all throughout airports, and so if you were to build in some sort of AI that's able to recognize when somebody collapses, that might be a way to activate an emergency response system quicker than somebody getting on the radio or somebody calling a central dispatch center. This technology may be useful in other environments such as theme parks, shopping malls, and casinos. So not just limited to airports, but anywhere where you have really high penetration of security cameras that can get broad scope of what's going on. We can also take it one step further. There's camera measurement of physiological vital signs now. So maybe somebody is, if they're deteriorating, maybe not to the point of cardiac arrest, but they're maybe clinically deteriorating, there's a technology that can say, hey, this person's SpO2 dropped about 30 points in the last 2 minutes. Maybe we should call 911 or activate an emergency response system, regardless of if they end up in cardiac arrest or not. Second one is eCPR, extracorporeal life support. So we started with surgical cardiopulmonary bypass. The machines got smaller and were first used outside of the surgical setting in ICUs, but now we've taken it even one step further to pre-hospital extracorporeal life support. So VA ECMO basically siphons off venous blood, oxygenates it, and then redeposits it as oxygenated blood in a patient's body. So that might be a really cool next step here. So early ECMO and cardiac arrest may be associated with improved survival. So we have the arrest trial from, oh, I have this wrong. The arrest trial on the left is Minneapolis, Minnesota, whereas on the right, the CHEER trial comes from Australia. There was a meta-analysis a few months ago by Squizzato that showed extracorporeal CPR is associated with increased survival and favorable neurologic outcomes, especially when the initial rhythm was shockable. And Paris is really on the cutting edge of ECLS. So here on the left, you have ECLS taking place on the subway, and on the right, ECLS taking place in the Louvre. So like they're really bringing this out to the streets, bringing what was once a surgical technology out to the streets, and I think it's just the coolest thing ever. So I wouldn't be surprised if in the future EMS agencies on airports are initiating ECLS and then taking care of it. This photo comes from Minneapolis, Minnesota. They sort of have an ECMO truck, and the ECMO truck responds to refractory out-of-hospital cardiac arrest. Here's an internal shot of what's going on. And so if you have this on an airport, you can get really high-quality care to cardiac arrest victims super, super quickly. So it's just music to my ears, and I can't wait. So I wouldn't be surprised if 20 years from now, ECMO initiation by airport EMS is commonplace. But I want to sort of plant the seed now. Thank you so much. We went through a lot over the last few minutes, but I really appreciate your attention. I want to shout out because I promised the crew of Delta 2509 who flew me from LaGuardia because they let me take a picture, and I promised them I'd shout them out in this talk. Here are my contact info. You're more than welcome to contact me anytime, and thank you so much for your attention. Appreciate it.
Thank you very much. We have a few minutes, so we have questions we'll open up the floor for questions for all the speakers.